It is just a huge honor to be sitting in my home and having one of my rock star idol role models, Dr. Ann L. Koch, come all the way over to my home. On Dentaltown, she put up 6 courses in endodontics, and you're the most viewed endodontist on Dentaltown. And so let me read your bio. So Dr. Koch received both her DMD and certificates in endodontics from the University of Pennsylvania. She is also the founder and past director of the Postdoctoral Program in Endodontics at the Harvard School of Dental Medicine. Following her clinical and academic career, Annie created her own successful technology development company, Real World Endo, of which she was CEO and president. Although Dr. Koch is no longer actively involved with Real World Endo, her passion still burns brightly. Women's issues in dental medicine and diversity challenges as a whole are key points of interest. Accordingly, Dr. Koch is very involved with women's issues in organized dentistry, as well as maintaining a faculty position at the University of Pennsylvania School of Dental Medicine. Dr. Koch also maintains a position as a senior fellow with Penn Medicine. You have to be the most accomplished endodontist on earth. I mean, I can only think, if someone said, who's the most accomplished? It'd be either you or Stephen Cohn. Right?
Okay, well, thanks. I greatly appreciate it. And first of all, I'm thrilled to be here with you, Howard. And, you know, I was so thrilled to do the keynote with John Koch, who was a classmate of mine. Back in 1973, I was KOC, John was KOI, so we sat next to each other for 4 years in dental school. I've known John for 44 years, so that was a great time for me at the Dentaltown meeting. And, you know, we just had our 40th reunion 2 weeks ago at Penn. A couple of things to update the CV. I'm thrilled to be back engaged with Real World Endo. So that really pleases me completely to be back involved. And another thing, I made a very significant contribution to the University of Pennsylvania. When I transitioned, there were a couple of years where things were pretty challenging because nobody really had done this. Certainly no one at my level had changed gender. And even though I thought I had done it pretty successfully in many different ways, it wasn't so easy. Then Penn reached out to me. They actually had kind of an unofficial Ann Koch Day at the dental school. I met all these wonderful students, and I stepped up and I made a very significant donation. And 2 weeks ago, they had the official dedication of the Ann Lauren Koch room. And it's a big room. It's a big room. It's a very large lecture and seminar room. And I'm so completely thrilled to be able to do that. And listen, I'm going to be very honest. Having a room named after you in an Ivy League school is way cool. So don't let anybody kid you that it's not. It's way cool. But there's something here far more important. I'm having another plaque made on the inside of the room. And this room has been gifted to acknowledge the existence of LGBT students, residents, faculty, and staff. And at the end of the day, you've seen my presentation, Howard. I show a wonderful picture of me with a bunch of people from Penn. They're LGBTQA supporters, allies, students. And at the end of the day, I say to people, look at this picture. Look at the diversity. Look at the heterogeneity. And most importantly of all, look at the humanity. That's what it's about. That's what it's about for you and I as healthcare providers. That's what it's about, the people out there who are viewing this or listening to this. It's a privilege to be a healthcare provider. At the end of the day, there's no room for bigotry and prejudice. We know, you and I both know what goes on, whether it's sexual orientation, racial, whatever, who knows. But there's really no room for that as a healthcare provider.
Well said. I've had so many emails over the years about this podcast saying they so love that I mentioned that my little brother Paul, right, who's 17 years younger than me, is gay, because they always say the same thing. I'm a gay dentist in a small town in the South, and I'm so fearful that someone will out me because it will just be a nightmare. And I'm like, dude, it's 2017. You can't let people know you're gay in small towns in Texas and Alabama.
The transgender thing has all of a sudden blown up, but a number of years ago, and I transitioned gender back in 2013, and I was 63 years old when I did that. That was kind of right at the beginning of this explosion of this transgender thing, and I've just written a book for Rutgers Press, and that should come out this next year, and the name of the book is It Never Goes Away, Gender Transition at a Mature Age. it's a little bit of a cautionary tale because things have gotten way ahead of themselves. And where they've gotten way ahead of themselves has been on people over 55 and kids less than 18. There's legitimacy to both sides of that, but there are a lot of people coming in who really have to basically be better informed, think more clearly, more circumferentially through the entire process. For us as dental providers, I'm now starting to get feedback from dentists. Wait a second, all of a sudden I've gone from like 0 trans patients to 20 patients. Listen to this, Howard, this is amazing. I got a phone call maybe 2 months ago. I've gone around for the last 2.5 years to many, many medical conferences, being a keynote, talking about my transition, my own personal experiences, transgender health. And I got a call, and it was from a pediatric dentist at a very, very well-known children's hospital in the Midwest. So he introduced himself, and that was terrific. And he said, I said, why did you call me? He said, well, I was given your name that I should speak to you about this issue. So I said, fine, how can I help you? He said, listen, he said, I came here to this hospital 22 months ago. There was a transgender adolescent program. We had 18 patients. He said, 22 months later, as I speak to you tonight, was on the telephone, he said, we have over 600 patients. Like, what the heck is going on? So when we're starting to see that kind of input into our patient population, into our patient pool, people have to kind of try to figure out, is there any special things that we need to do? Is there any type of accommodations we have to make? And I think as dentists, it's much easier working with that population as compared to our primary care physician friends. And that's not particularly difficult for them, but that gets into blood panels, hormone administration, things like that. But for us in the dental world, I think the thing dealing with transgender patients is, first of all, you want to create a welcoming environment. And I think you and I both agree, we want to create a welcoming environment for any human being, but especially these people. And I think one of the things here with this is creating forms in your office that express gender identity. What is it now? Google has 19 different terms or something, one of these groups. And I'm really big on gender affirmation and gender nonconforming. I think far too many young people, less than 18, far too many people over 55 go a surgical route, when I think there's a lot of other options for these people, but that's another discussion. But for us as dentists, we want to create a welcoming environment, have forms that properly reflect your gender identity, have gender neutral bathrooms. That's like a no-brainer. I think you want to have a staff that's kind of trained a little bit in how to ask these individuals questions. Don't pepper them with trans questions. And here's the most important thing when working with transgender individuals, which I have found: do not assume anything. Just ask. And I think one of the things is, I remember when I was transitioning, and I did it at Boston Medical Center, and I had some good fortune of being able to go through the women's primary health clinic at Boston Medical Center. So I would be sitting there, and this was before I had, the final surgery and all that stuff, but it kind of looked like what I do look like now, but maybe a little bit thinner. And I remember one day this young woman comes out, this young Spanish woman, and there's like 5 ladies and myself, and she goes, Kenneth Koch. Nobody moves. I don't move. She goes, Kenneth Koch. Nobody moves. Then she bellows out at the top of, Kenneth Koch. So I raised my hand and I said, come over here. I said, first of all, to you, it's Dr. Koch. So I said, secondly, I said, what we're going to do is we're going to make this an educational experience. What I want you to do is I want you to write my name in front of the chart, Ann Koch. She goes, well, your insurance card doesn't have that name. I said, they don't have it right now. They're going to have it very shortly, but I want you to write my name. She goes, I can't do that. I said, yes, you can. She says, well, I'll have to speak to Dr. Siegel, who's my primary care provider. I said, absolutely. Let's go over and speak to Dr. Siegel. So we go over in tandem to speak to Dr. Siegel. Of course, what does Jenny say immediately? Write the name on the front of the chart. That's just being a little bit considerate. It's being a little bit, forward thinking. That's the way working with these patients. I think, Howard, for our dental colleagues, when they're working with trans patients, when you treat them with respect, you're going to be stunned at what grateful, appreciative patients they're going to be. Because a lot of these people have had a really, really tough ride. For me, when I wrote about it, it was a little bit different. I had a lot of life experience. I think I have an intellect. I had resources. I had an image of what I wanted to do, and I was never dysfunctional. This was just something I thought about, but it never made me functional. I was very functional. I was very successful doing what I had done. My world changed when I had a squamous cell diagnosis at age 63. I realized I had been compartmentalizing this my entire life, flip all the cards over, I've got to do it. And that's not particularly uncommon with older people. But for me, I was never dysfunctional. I never thought about suicide or anything like that. But it was always there since I was like 4 years old. And when mortality hits you, be it a car accident or a cancer diagnosis, there are certain things that you want to do. And I just felt I had to do this, and so I did it.
So just to be specific, every dental chart should say, ask if they're male, female, or...
Gender nonconforming.
Just gender nonconforming?
Yeah.
And is there a hyphen or just gender nonconforming?
Gender nonconforming.
And explain really what that means.
Well, what has happened, this is a whole generation, and this has been an amazing thing, and I think this is terrific. Basically, you know what this means? If you're a guy and you're kind of an effeminate guy, it's okay. If you're a young woman and you're kind of butch, it's okay. And what happens, gender nonconforming, are a lot of young people, especially, that's not exclusively young, but especially, let's say, less than 40, who see that they don't identify either as male or female. They identify as themselves. And in fact, in terms of pronouns, they will use very often the pronoun they. So, when I'm speaking or communicating with medical schools, many times I'll see emails come with people's name and they talk about preferred pronouns, like Howard. Hi, I'm Howard. Preferred pronoun, he, him. I'm Andy. Preferred pronouns, she, her. Then somebody else, Ty. Preferred pronouns, they, Z. So that's just something. This is how things change. This is how generations change. But what I like about not just gender affirmation, I like this idea that gender is a continuum. It really is not black and white. There's so many things that you and I grew up, we saw it as black and white, good and bad. And that's not really the way these people, I see themselves. And I like the fact, I've done videos for Dentaltown on the endo restorative continuum. I like the concepts of continuums because there's a connotation, there's an implication that it's somewhat fluid and you can move along. And I've met some gender non-conforming people who some days kind of present more as kind of a guy. Other times they present more in a feminine way. They're happy as long as they're productive. That's their vibe.
Well, I just appreciate so much how you had the courage to be a role model, to come out and make this public. Was it frightening? Did you fear a backlash, non-acceptance?
Probably because
major endo companies would want to have nothing to do with this.
Well, the interesting thing was, I think that was some other people's concerns. My concern initially was, well, wait a second, I've done so many different things for people. I've been out there, people have known me, and they're going to understand that I'm basically the same person. That was a miscalculation. And that's why it took a couple of years to get things to come around. So for me, I miscalculated how toxic it was. And one of the things that to me that was so interesting was that I thought, and I talk about this in a book, I thought the people that I knew for 40 years would be my strongest allies. Well, it's not necessarily the case, because what happens, those people somehow felt they had been duped, that I wasn't honest with them all these years. And I was completely honest with them, and it was just something you compartmentalized. And so that was a little bit of a surprise that the people who I thought would stand up and have my back, they really didn't. And as I talk about in the book and as I show in my lectures, and I do show pictures, as you know, when I went through some of this facial plastic surgery, the only support I had going through this entire thing was a stuffed moose. And I remember lying in the hotel room up in Boston after being dismissed from the hospital, with Barton's bandages, the whole 9 yards. I remember sitting in the hotel room thinking, looking at myself all swollen and black and blue, thinking, what the hell did I ever do to piss off so many people that here I am doing something so important and my support system is a stuffed moose? That was amazing to me. Like, I couldn't believe it.
Was that rock bottom?
Rock bottom was even after that, where people who kind of a little bit more purposely were kind of working against me and different things. And, it's one of these things where I think if I didn't have such a strong personality, and I do have a strong personality, it would have been really tough to handle, because I'm trying to think like, what did I do? You should be happy for me. Someone should be saying to me like, oh my gosh, Annie, I'm so happy that you did this. Oh my gosh, it took a lot of courage instead of trying to bury me. So that was the rock bottom. After that stuff had been done, but
You were saying friends and family. I mean, friends and colleagues. What about family? Were they?
No, that wasn't particularly supportive of all. My brother, who was a great brother growing up, but he and his wife are quite religious, and I never had any children. But his thing kind of was like, well, I'm supportive. And I said, well, I don't think you're really supportive. And then it was kind of like, well, I'm supportive because I don't want you to go to hell. Like, what kind of support is that? I don't think that's particularly supportive. So what was really kind of interesting was that I had to pull back. It's like taking a 5-yard penalty with the Phoenix Cardinals, Arizona Cardinals. Take a 5-yard penalty, drop back, do a timeout, suck on some pressurized oxygen and try to figure this thing out. It took me a good 2 years of just trying to figure out what's going on here. I was doing some things in the trans community, but I wanted to get back into what my love is, which is my specialty, which is dentistry and endodontics. My whole world changed in the summer of 2015. I had gone to the University of Pennsylvania for many years, played sports, worked in the dining service, got married on campus there. And I get an email from the alumni office that they had been at the dental school and that they found out I had changed my name and no longer lived in Palm Beach. I had a home down in West Palm, beautiful house. I had a beautiful home in the end of Long Island. So when I saw that email, I realized, oh my gosh, they know, I'm going to call them. So I call them. The next day, Howard, I get an email that is still the most stunning email to me I've ever received in my life. And like you, I've received lots of emails. It was the most loving, heartfelt, warm, humanistic email I've ever received in my life, and it was from Sing-Kook Kim, the endodontic surgeon Sing-Kook Kim, who had been kind of a mentor of mine at Penn, and it was amazing. So what happened was that when I saw this email and he invited me down to Penn, I went back and they had this unofficial Ann Koch Day at the dental school with all these kids. He acknowledged all the different products and techniques I had developed and created. They were using some of these at the school. They didn't even know I had developed them, which was wonderful. That led to my association in a much closer way with the school. It led to me stepping up and making a donation, which I was very proud to do. It ended up amazingly being elected to the board of overseers for the school. And I'm very, very involved with the veterinary school as well. So as far as I'm concerned, University of Pennsylvania really became my family. And University of Pennsylvania, to me, I'm a ferocious defender of how terrific the entire university is. And I think the dental school has really set some great standards. So that really changed my world. And what happened was that you kind of get your mojo back, I'm a person who spent a lot of time in the water. I still love being on the water. Worked my way through dental school as a commercial rod and reel fisherman out of Montauk. Still love making fishing rods and all that kind of stuff. But it took me a couple of years to get my sea legs because the blowback was just so much in extreme of what I anticipated. But the good news is a lot of the people who initially were standoffish just didn't want to be the first. And that's kind of human nature. So when people I had known, partners, people like that, people involved with some of the different companies I work with in endodontics and in dentistry, once a couple of people realized, well, wait a second, this is kind of like the same Dr. Koch, everybody's kind of come back. And that's pretty unique in the trans world. And what I'm really very happy about is, as I said, I'm very happy to be back with Real World Endo. I'm happy that Dr. Nase, who I had chosen to replace me as CEO and president, we're doing a lot of things together. I think Dr. Brave and Dr. Nase did a good job of keeping things going. And I think that's a lot to be said for that. So
is it going to be the Annie and Ollie show now?
Yeah, basically. Yeah, A&A.
So will he still be the president, or will you?
Yeah, no, he's doing that. And Dennis had served for a number of years as the trustee, or one of the trustees with us, and I appreciate what Dennis did. And then, Dennis graciously stepped aside, and I came into the position that he had. And, I in retrospect, we kind of both did some things that we wanted to do. I had a wonderful relationship with Dennis, as you know, and I can still consider him a friend. And, one of the things that made our relationship work, Howard, was that we were very different. Maybe it turned out a little bit more different than maybe we both would have thought, but that's what made it work. I had things that I could do well. Dennis had things that he could do well. And I think at the end of the day, maybe things have worked out kind of the way we both maybe hopefully would have hoped for. I can't speak for Dennis, but I can speak for myself. And so
he retired?
Yeah, he's retired now, and from what I heard, I don't really have much communication, but I understand he's doing well, and I think that's terrific. And of course, Ollie, I think, is happy to have me back because everybody's different. I think, with Dennis and I, when we were doing all our courses, what made it work, it was a yin and yang. It was a total yin and yang situation. And with Ollie, it's also a yin and yang, a little bit different yin and yang. Dennis was a little bit more reserved. Ollie's a little bit more of a different generation, more with tech stuff. I'm, like you, out there, okay? And, it's funny because years ago people would say something like, well, you're kind of high maintenance. I said, absolutely not high maintenance, complicated. So there's a difference. But I'm very pleased kind of where I've gone through with this trans thing. I think I've done a lot of good at these different medical meetings. First of all, medical world does things very different than dentistry. It's like 10 minutes, you get 10 minutes. I'm not doing 10 minutes. If you want me to show up, I've got to do at least 45 minutes, preferably an hour to an hour and a half.
For your lecture?
Yes, absolutely.
Now, is your lecture that you just did at Townie, is that going to be a course on Dentaltown? Is Howard Goldstein going to make that a course?
Well, if you want to, I'm very happy to put up a course with something or having a course where...
did they tape the one you did?
Yeah, I'd like to. Yeah, we're going to work through that. I'd love to work through that and make that a course.
Because one of the reasons I really didn't want to podcast you,
right,
because your story is the pictures,
right, it's
the
a
visual. It's such a better story. In fact, if you get anything in this podcast, you got to log on Dentaltown to see the story. I mean, the way you pictured and show that whole story, what an amazing presentation.
Thanks. And, that's resonated. I've been a number of places. This year at ADEA, which is the American Dental Education Association, I was one of the keynotes. And they haven't had a keynote speaker who's been a dentist in years and years. The other keynotes were the CFO of Google, the first black female astronaut, Hillary Rosen, who's a CNN political commentator, and Ana Navarro, who is a Fox TV political commentator. They were the other keynotes. And Rick Valakovic, who's the president, wrote an amazing review of the whole meeting, and he thought that I was the most charismatic of all the keynotes. That's kind of the feedback of the meeting, and I'm so thrilled about that, and they taped that. But it was really a big deal for me, and that morning I did 2 lectures for ADEA. I did a keynote at night, and I gave a 90-minute presentation in the morning to a packed room, and at the end of it I had a standing ovation. And I've had that at a number of medical conferences, and so for me, that's really incredibly, incredibly satisfying, because that's kind of like coming full circle. And so that's a big deal.
Yeah, democracies are so brutal on the minorities.
Oh, I mean, listen, one of the things that taught me was that all of a sudden I had a totally different appreciation for black and brown. I had a totally different appreciation for lesbian and gay individuals. And, there's many transgender individuals who kind of lead a life as trans individuals. To me, that's not what I did. To me, it was about being a professional woman. And I write about it in a book that my goal was to kind of be at a University of Pennsylvania alumni function as a professional woman. That's kind of my goal. And it's funny when I show up, they see me show up and they think, what's this Upper East Side bitch going to be talking about? And then after 10 minutes, you realize, oh my gosh, she really cares. I totally care. Okay? My style is my style. Everybody has their own style. But I do care. And one of the things that's been a wonderful sidebar to this for me is I'm back into athletics. I had walked away from big-time athletics because I couldn't handle the locker room. And when I transitioned, I got back into, and I won the Northeast Senior Women's Tennis Championships 2 years ago. And I don't play like a guy. I probably lost 60% of my strength doing this, which is an interesting thing people don't talk about. But I like playing tennis. I play tennis really well. And in the course of doing that, I beat at the time the #1 senior women's player in the country. And so I was really pleased about that. Does anybody know? I have no idea. I have no problem saying to people, if somebody asked me, I'd say, yeah. But, you don't go around saying to people, hi, I'm Ann Koch, I'm a transsexual woman. I was a guy for 63 years. That's not a good way of starting conversations, either with a woman or a guy. So I played, and I just played like any other woman, and I happened to win it. But it's very gratifying to me. And here's one of the things. I walked away from big-time athletics because I couldn't handle the locker room. In high school, there was never a team bus that was going to leave Smithtown High School without me on it. I was all Long Island in 2 sports. But in college, everybody's all this, all that, all whatever. So it's a whole different game. But now I find myself in women's locker rooms, and I belong to a beautiful tennis and beach club on Cape Cod. I have girlfriends who come up to me, and they'll say to me, Howard, listen, Andy, do you have a couple of minutes? Can I speak to you about 10 minutes about something? And it's always about business. They're looking about starting their own salsa business. They're looking about starting a pie business or a home catering business. So they know I have a lot of business experience, and that's incredibly rewarding to me.
Well, Real World Endo is a serious business.
It's a serious business. And, that was one of the things with...
that's bigger than anybody's individual endodontist practice.
Absolutely, and it was bigger, and you could ask Dennis the same thing. And one of the things is I have tremendous remembrances of what Dennis and I created. We created a whole big thing, and it was a big deal. And Dennis would say this. I believe we were the biggest continuing education company in the world for a while.
Yeah.
And we did a lot of courses.
So it looks like we'll be knowing each other for a long time because my sisters tell my little gay brother that he's going to hell for eternity. So, I'm thinking, do I want to go to heaven for eternity with my boring sisters or go hang out and party with Paul?
Well,
Paul is absolutely the sweetest, nicest, thoughtful person in our entire family, has done everything for everyone, and he's the guy going to hell.
Well, yeah, and again, what happens is that people have to realize, and I think most gay and lesbian people now realize, and transgender people, that that's not going to happen. But people sometimes get buffaloed, especially younger people. One of the things that's really become an issue for me is somebody referred to me when the transgender health thing as the accidental activist. I'm definitely not an activist, but what I am, when I have this preface in my book, in the book, I talk about that I don't represent the far-right agenda, nor do I represent the transgender agenda. I'm looking for veracity. I'm looking for the truth. And that's the space that's sweet to me, And so, for me, I talk about things in transgender health because I was have been a very unique individual in that I was both looking through the prism as a patient as well as looking through the spectacles of a healthcare provider who had seen more than 32,000 patients. So that was pretty unique.
You've seen 32,000?
In my career, I probably saw more than 30,000 patients.
So you've done 30,000 root canals?
No, I did pros for 14 years.
Oh, that's right.
So I've done thousands and thousands of
So
crowns.
you're a prosthodontist and an endodontist.
Not an official prosthodontist because I never got the degree, but there were a couple of guys like us in the Air Force. I was chief of pros of a number of bases. I also was head of all the lab work for all the Air Force for all the Pacific. And I used to actually take my dies and I would ditch them with a 15 blade underneath a microscope. So I was serious. So all the endodontic products that I've developed and what Dennis and I developed at Real World Endo, we reverse engineered from the final prosthodontic result. And I have to tell you a funny story before I get into women's issues, because I want to talk about women's issues. Gosh, this must have been 8 years ago, 9 years ago. I get a call at home. I was living on Long Island from a very, very famous New York City, Manhattan prosthodontist. So he calls me at home. He's surprised that I answered the phone. So he introduces himself, and I knew who he was, and said hello. And he said some nice things about Dennis and I, which was great, and about the endo sequence system. So he said, you know, I'm doing a lot of root canals. I'm doing a lot of endo in my practice. I said, really? He goes, you mad? So no, I said, I'm not mad. I said, you know, he said, really? I said, no. I said, it makes all the sense in the world to me. If you're doing a crown prep and the tooth blushes, becomes pink, that's cooked. Do the endo. I said, if you do a crown prep and you turn away and you turn back, it's kind of brown or purplish, that's thrombosis. Do the endo. And one of the great articles I ever got response from was an article called Do the Endo, Dude. So I said, no, I'm not mad. He goes, really? He said, then he got kind of defensive, and this is a big guy. He said, I'm only doing anterior teeth and premolars. I'm not doing molars. I said, well, if you were doing molar endo as a prosthodontist in New York City, you should have your head examined. He said, no, I'm just doing premolars and anteriors. I said, fine. He said, you're not mad? I said, no. He said, oh, there's another thing. I said, what's that? He goes, I can't believe how much money I'm making doing endo. And I replied, now I'm pissed. But it makes all the sense in the world.
When did you write Do the Endo, Dude?
That was for dental economics back, I'm going to have to say 2002, 2003.
Man, you should update that and print it in Dentaltown.
I'd love to redo it. I'd do that,
it's
absolutely.
a very common question that the young kids
No,
have.
and I talk about because years ago with the thickness of porcelain required, we talk about, I would never do crowns on lower anterior teeth without having them devitalized. The situation, and one of the things I talk about in lectures that's so true, especially for the young dentists listening, is you do 6 units across the front. I don't care whether they're laminates, I don't care whether they're single units. And number 10 is close. But Mrs. Jones, complains so much about the price of this. If you tell her that she needs a root canal and it's another, $900, whatever, she just may go crazy and drop the entire treatment plan. So then you go into evasive action. You put eugenol in a temporary. You try this, you try that. I've done all that stuff. But at the end of the day, here's what you have to do. If the tooth is close and you think it may need endo, do the endo, dude. Because I've been on both sides of the tooth. You are never, ever going to have any patient who enjoyed being told that they needed a root canal. You are never going to have any patient who enjoyed being told that, excuse me, sir, ma'am, your treatment plan just went up another $1,200, $1,400. But while they don't understand this, while they don't like hearing this, they understand it. They don't like it, but they understand it. You don't do the root canal. You cement all the units. Then you've got to go in through their beautiful new crown and do a root canal on number 10. And God help you, if you break the porcelain, you bought yourself now a really angry patient. So the whole key thing here is, yes, they're not happy to hear the news, but do the correct thing. If it's going to require endo, do it now, because they will understand it.
I sometimes think they worship pulp. Like, you see all these people talking about these elaborate pulp capping techniques. What do you think about pulp capping in general?
No, I think first of all, there's a couple of things with pulp capping. And, one of the things that's going to be interesting is that bioceramics is the real deal.
Why?
Because of the physical properties of the materials. Bioceramic is like a bone cement. In other words, bioceramic, when it is set and it's driven by the moisture in the dental tubules, which is like 40%, it's a hydration reaction. So a hydration reaction at the end of the day is going to spin off water, which continues to drive the reaction. But the other thing it spins off is hydroxyapatite. So the hydroxyapatite is a big, big deal. And so what that does, it allows us also to help you get bonding and helps us close the gap between the sealer and gutta percha. Also in terms of a high pH, in terms of being bioactive, in terms of spinning off hydroxyapatite, the BC sealer, the bioceramic, is a great pulp capping agent. And what I like to do with pulp capping, and this is changing the game with pulp capping, what you do with BC putty, you have to understand with bioceramics, what changes the setting time is the particle size. So BC sealer, and this was a big thing that Dennis and I wanted. We wanted to have it less than 1 micron. And you can push it through a tuberculin syringe. That's BC sealer. The repair material is a little bit larger than 1 micron, and the putty is a little bit larger than that, and the facet is even a little bit larger. Anyway, but still a very small particle size. But what you can do with an exposure, if it's an accidental mechanical exposure, first of all, disinfect the area with some hypochlorite. You can get hemostasis, and hemostasis, Howard, is the first thing you have to do. So how can you get that? One of the things I've always liked to do is take a small, exquisitely sharp spoon excavator. You make a little slice and you hear the pulp suck back into the chamber, okay? That stops a lot of the bleeding. If you want, you can put some peroxide on a big tuft of cotton. You can put some sodium hypochlorite on it, but you can get hemostasis. Once you get hemostasis, I want you to place the BC putty on top of the exposure.
And who makes this?
Brasseler makes the BC putty, okay? So you put that right on top of the exposure, and then give that about 10 minutes to set. You don't have to send the patient home with a wet cotton pellet like MTA. Give it about 10 minutes to set. Then what I want you to do is I want you to put a glass ionomer on top of it. Use any type of glass ionomer. You can use Vitramere, I don't care, Fuji, whatever. But you put the glass ionomer on top of the BC putty material, you're going to get a bond, and then what you do is you etch the glass ionomer. Then you totally restore it. Boom. Too easy. Single visit. Okay? That's what you do with exposures. Now, how do I feel about mechanical versus carious? This is going to be a very interesting topic, and this is an opportunity for a multi-million-dollar product. If anybody can develop a product that can evaluate the pulp as to how much penetration we have with the bacteria. The dental pulp likes to compartmentalize things, and it compartmentalizes inflammatory cells. And a lot of schools now are starting to see pulp does a pretty good job about compartmentalizing bacteria. So what happens if you have a pulp, even in an adult patient that's not really contaminated, for instance, like a mechanical exposure, adult pulpotomies we're finding now work. That's going to get us into a whole nother issue in endodontics about ethics. In other words, do they need a pulpotomy, or do they need a full, total pulpectomy and obturation of the radicular tooth structure? Very interesting thing. Keep an eye on that.
And where do you think it's going to go?
I think it was probably going to go in the place where it's going to be based on the contamination. And I think it's also going to be you're probably going to see more adult pulpotomies come forward in the next 5 years. You're probably going to see an increase in the price of pulpotomies. I was at an endodontic study club and I said, listen, I trained residents, but they're $500,000 in debt. So look, what do we have here? You have a $1,800 molar root canal, or you have a $150 pulpotomy. And one of these well-known dentists said, make a pulpotomy $1,000. He didn't say that jokingly, and I didn't take it jokingly. I don't have an answer for you. I don't know where this goes. I can tell you that everyone's getting some preliminary results, like I think of years ago, indirect pulp caps. Indirect pulp caps don't work. We found that indirect pulp caps do work. I think we're going to find out in certain cases that pulpotomies on adults can work, but I think what's going to be key is how we determine the bacterial infiltration of the tooth, of the chamber. At this point in time, we haven't seen that.
You know, one of the saddest things when I got here to Arizona is the Medicaid,
right.
The state access. They paid the filling for pedo was $3 more than the extraction, and almost 4 out of 5 moms would tell me, "Well, it's cheaper to pull it."
Right.
And you're like, "Yeah, but you don't have a tooth."
Well, let me
for
tell you.
$3.
Let me tell you why this is the second coming of this for me. I graduated from dental school in 1977, and the first year I worked in West Philadelphia in a health clinic, and honestly, I was the only white person I saw the entire year. I didn't even see many Spanish people. It was an African-American area, African-American students. And it was mainly a lower income, and at the time, the Department of Public Assistance in Philadelphia, Pennsylvania, called DPA, did not pay for any endodontic treatment. So I had all these young kids coming in, and I realized if I continue to excavate the decay, I'm into the pulp. Goodbye tooth. we had been told at Penn that indirect pulp caps don't work. So I figured, screw that. I'm going to do what I think is the right decision. So what I was doing, I started doing indirect pulp caps. And listen to this. I was doing it with Dical, right? And then I found out something. You know what I was finding out? They worked. And my idea was, if I could buy a couple of years, maybe this individual would have a job. Maybe this individual's parents would be in a situation where maybe they had some kind of insurance or something. So I was trying to buy time, but I realized that, oh my gosh, the indirect pulp caps work. Had to be 2.5 years later, all of a sudden dentistry changed. Forget what we said about indirect pulp caps. Indirect pulp caps work.
And why did the Dical work?
Just because it was calcium hydroxide covering, and it was able to stop and somehow arrest or do something to the bacterial penetration, and it worked.
Do you think it was because of the pH?
Yeah, pH, just like what calcium hydroxide. You know, a lot of endodontists, including myself, have done a majority of the cases single visit. But there are cases that I never did single visit. I would do multiple visit. But the medicament of choice, especially in necrotic teeth, is calcium hydroxide. And the reason it's calcium hydroxide is because the pH. The pH is about 12.8, which is the same as the bioceramic material.
Andy, podcast audience are younger.
Yes.
People our age are reading textbooks and going to conventions. Right. One of their most common questions is, they're so confused on one-step versus two-step. Some people say if there's any periapical radiolucency, it's got to be a two-step. But it seems to be an extremely common question on Dentaltown.
Yeah. And
are you a one-stepper or a two-stepper?
Well, first of all, probably of all the root canals I did in my career, probably 65% were one visit, 35 to 40% were two visit. If a tooth was vital and there was no infection, I mean, obviously that's a one step. But even if some necrotic teeth, I would do if it was asymptomatic in one visit. It's easy to say which cases would I not do a one visit root canal on. Well, if I ever had a mandibular posterior tooth, meaning a mandibular premolar or molar, if it had an area and it was symptomatic, and symptomatic to me means the pain and or swelling, I would never do that in one visit. Here's why. If I obturate that case and that tooth blows up and I have to IND it, if it goes to the lingual side, because I can't establish drainage through the tooth because I've already filled it, if it blows to the lingual side, INDing in the floor of the mouth is a plain mess. The floor of the mouth is very vascular. I don't want to be sticking a blade there. If it blew to the buccal side, trust me, INDing near the mental foramen is kind of a tight shorts type of situation for men and women because you're right near the mental foramen. You don't want to nick the mental foramen when you're going down the bone with your blade. So that case of mandibular posterior teeth, then necrotic but symptomatic, didn't do in single visits. If I had a case that was draining, there's active pus coming out, I'd never do that in a single visit. Even if it had a fistula, which is kind of like, nature's safety valve, I still wouldn't do that in a single visit. If you have a tooth that's draining a lot, I would take the rubber dam off, have the patient use warm saltwater rinses, warm to hot saltwater rinses for like 5 to 10 minutes. That would bring out a lot of the drainage, go back in, and if I could close the tooth, I would. If not, I'd bring them back, but I would never do that in one visit. So if the tooth is draining, you can't do that in a single visit. Another case, silver points that are symptomatic. If somebody came in with a silver point case and was asymptomatic, even if it had a little bit of an area, I would one-step that. But if they came in with a silver point case that was symptomatic, again being pain and or swelling, I never did that in one visit because those teeth are really dirty cases. When you pull out the silver points, and a great way for pulling it out for the young people is to use a headstrom. Get a headstrom hand file, engage it into silver, which is a soft metal, and you pull it, and out comes this silver point that's going to be black because all the corrosion products right along your headstrom hand file. So I wouldn't do that in one visit. Another case that I wouldn't do in one visit, if it was going to take me an enormous amount of time. And if somebody has a patient, let's say you've got a patient and you're in Chicago and they've got to fly to Johannesburg, South Africa the next day and they need the root canal done, don't go into a marathon appointment like 3 hours. First of all, everybody should be using bite blocks when they're doing posterior endo. And the bite block they should be using is not the NBA oral surgery large size. You're going to disarticulate your patient. Only use junior or child-sized bite blocks. You put it in the upper side of the arch, and people do fine. If you have a marathon appointment in endo and you don't use a bite block, When you get done, you take off the rubber dam apparatus, and then you say to the patient, okay, Howard, you can close. You know what the patient says? They can't close. They've slid out past the eminence, and now you've got to grab the mandible with 2 hands, pull it to you, and then put it back up. It just goes back up into the joint very easily. But those are cases where you shouldn't be doing a one-visit endo procedure. There's other practicalities. You can, even as a management person, if someone's never paid you for previous root canals, why would you do a single visit? I mean, think about that. I mean, people will do fine with calcium hydroxide. That's your own business decision. People make that. But I mean, for me, the big thing is in terms of symptomology, pain and/or swelling, and whether they have a lesion or not. I know endodontists who do everything one visit. I never subscribe to that. I know endodontists who do everything 2 visits. I don't subscribe to that. I think it's kind of a case-by-case thing.
They're also confused on the market. There's so many file systems.
Oh my gosh, yes.
And on podcasts, they always want me to ask, what do you use?
Well, first of all, this is going to be obviously a biased answer to me because Dennis and I created the EndoSequence system. So for me...
And who sells that?
Brasler sells that.
So Brasler sells all your inventions and patents?
Pretty much now, yeah. There was one thing I had created years ago for Cybrone called Smear Clear. Smear Clear is a great... it's basically EDTA with a couple of surfactants. And what it does, it removes the smear layer and opens up the dental tubules. So I like Smear Clear still because if you're using a bonded endodontic filling technique like BC Sealer, okay? If you're using a bonded obturation technique, it really helps to open up the dental tubules because when you do that, not only are you getting a chemical bond to the wall, you're getting a mechanical bond.
So that's by Cybrone, which is owned by Kerr,
right?
Which is owned by Danaher.
Danaher, right? That's called Smear Clear. It's a great product, I think.
Now, does Brasler, do they sell that direct, or do they sell that through dealers like Patterson, Shine, Ben?
Both of those companies sell it direct. Brasler is a direct company. I believe that Cybrone still is a direct company.
Really, Cybrone's direct?
I believe they are. They may have changed now because they've had some different changes of ownership.
It's interesting because in Dentsply, which is now married Sorona, Dentsply Sorona,
right.
Their Endo division, their Tulsa Dental division sells direct.
Right.
But all their other ones go through dealers.
Right. And one of the things on that in the past was, I was kind of involved with that many years ago, was the fact that there was an idea that endodontics and the changing nature of instrumentation and obturation required more education on behalf of the sales rep.
Right.
So I think in the dental industry, there's a little bit of that distributor reps, a little bit more, and the direct companies have sales reps that have more of an educational component to their job.
And we see that in implants too.
Yeah, right.
Implants. So implants are the rep only talks implants and endo.
Right.
So your file system sold by Brasler is the EndoSequence?
Right, EndoSequence, and that was all reverse engineered from the final prosthodontic result. And the big thing about EndoSequence, and Ali Nasser and I just yesterday completed a great course for Smile Brands. And what all these young dentists...
He was down in town?
Yeah, he was down in town, yes, in Scottsdale. What all the young dentists were just agog at was the synchronicity. One of the things I'm very proud to say was back in 1994, I had the first endodontic program, first postdoctoral endodontic program to use full shank rotary files. The first endodontic program to use rotary files was UT San Antonio. They used the Lightspeed. Steve Sinier and Carlos Del Rio were ex-Air Force guys, and they had the Lightspeed, which is an oil drilling tip. And Steve and Bill Wild, they had the company. And so they were the first rotary instrument out of the gate, and it was at UT San Antonio. But the Lightspeed is a very short head. It's like a Gates Glidden. But at Harvard, I was the first endodontic postdoctoral program to use full-time a full shank rotary file. And we used the Series 29 profile at the time. There was no, books like, rotary files for dummies. So we had to learn everything on the take. So we learned as we went along. My residents, I had 5 residents that first year myself. But one of the things I learned very quickly was like, oh my gosh, we can get predictable shapes. Constant tapered rotary files create a constant shape. A variable endodontic technique, every canal is shaped differently because the tapers are differently. That's why variable taper's always been associated with a thermoplastic technique. I started playing around in Boston in 1994 with single cones, glass ionomer, and I found at the time that if I used a 04 taper, the hygienic fine medium cones were a pretty good match. If I used an 06 taper, the hygienic medium cones were a match. Eventually, once I created Real World Endo, and I started to play around with gutta percha, I changed the molecular weight of gutta percha. So I made it stiffer. By changing the molecular weight, you made it stiffer, because I realized I can have a gutta percha cone, and now if I laser verify it, it can match the preparation exactly, just like a post. And I used to go around saying to people, what's the best post drill in the world? It's your last rotary file. And also for all my endodontic residents, I always taught them to use a rotary file like a post drill, straight up and down, not going around the anti-curvature. So when I would finish with a 3004 or a 2506, it was a 3004. It wasn't a 3104 or a 31 and a half. It was a 31. So I had precision with my preparation. I can now get laser verified paper points, laser verified gutta percha cones to match that, and then I created a custom-made post system that matches it precisely. Because, you know, I as I say to people, there's lots of endodontists who've done many more root canals than I have. There are endodontists who've done 45,000 root canals. I can't believe that. But I don't know of any endodontist who's done more crown and bridge than I've done. Okay, I've done thousands and thousands of crowns.
So Brazzler, you have the endo sequence. You have the files, the paper points, the gutta percha, all absolutely match.
And absolutely the post as well. And it's the only post system that doesn't weaken teeth because it's bonded.
Can I tell you something weird about post?
Right.
You said that if their kids are $500,000 in debt, they're not going to do a $150 pulpotomy when they could do a $1,400 root canal. Do you know why Japan went to self-etching for their bonding and we went to total etch? We did the phosphoric, the rinse, all that stuff. Japan went to self-etching because the insurance system of Japan, they just get 10-minute appointments.
Right.
So they're not going to do any system that takes long.
Right.
And with the post, when I was in UK, France, a lot of European countries, the fee for a molar root canal is $100. But they'll get another $100 for a post. So they'll put a post in every single canal. They have to. Right. Because $100 doesn't even break even for a molar root canal. So insurance systems determine a lot of technology.
There was a fellow, and he's at one of the universities I recently was at, and I kind of forgot which was the university, but his name is Steve Morgano. Steve's a prosthodontist, and he had been up in Boston for a number of years at the VA, was at Harvard for a year. That's where I met him, and he was at BU. He wrote an article in the 90s in the JPD, Journal of Prosthodontic Dentistry, about why people in Massachusetts, why dentists in Massachusetts use a post, why they place a post, and overwhelmingly. First of all, for people who don't know, Massachusetts is very energized about dentistry. Dentistry is very active. The general dentists, the Massachusetts Dental Society, we had our own insurance company, EDIC, they're very engaged. So Steve got back a tremendous response on his questionnaire. The overwhelming response by dentists in Massachusetts why they place a post in a tooth was, it's a code. And you know, one of the things in the military, I did probably thousands of abutments where I did an intraradicular core buildup. And what an intraradicular core buildup is for our younger viewers, that's where you have a tooth that's had a root canal, and you basically, for instance, on a maxillary molar, take 3 to 4 millimeters of gutta percha out of the palatal canal, take 1 to 2 millimeters out of the two buccal canals, and then we would condense our core material into that. Years ago, Howard used to condense amalgam. Sure. Then we were condensing like Ticor, Barry's company. You know, that was a good material. But that was called Musicant.
Ticor's Barry Musicant?
Yeah, right, yeah. So what happened was that was what we called an intraradicular core buildup. They don't weaken the tooth either. The problem is, in the civilian world, it's very tough to get paid for that.
Is Barry your buddy?
Not really. I know Barry. I think Barry's a friend. I see Barry. I haven't spoken to Barry in a while. But, you know, I used to see Barry at all the trade shows. And, you know, you have to realize I'm just getting back on the circuit. And it's really fun for me because Last year, which was 2016, that was the first AAE I had been to since 2012. And people were pleasant and stuff, and I think a lot of people didn't even know who the hell I was. And it's kind of like the nice-looking blonde or whatever, pleasant blonde, whatever term you want to use. And that was fine, but they didn't know who I was. And then all of a sudden, over the course of the last year, the words kind of leaked out. So when I went to the AAE this year, and I gave 2 presentations, one was on the bioceramics, the real story, and the other one was treating the transgender patient. Think about that. The AAE, I'm speaking at the AAE on treating the transgender dental patient. Anyway, I felt, and pardon the immodesty, I felt like a rock star. I had so many people coming up to me, saying hello and hugging me, and very quickly I established that if you're going to come back and say hello to Ann Koch, you have to hug. You have to give me a hug. And it worked. And I think part of this is they realized how comfortable I am in my own skin, and it makes them comfortable. And one of the things is it's okay to laugh. I mean, there's a lot of people that I have enormous empathy for in the trans world, and they don't seem particularly happy, and they've been so stressed out. They have such a difficult life. Fortunately for me, I've been able to do this in a way that I've been able to keep myself pretty much intact. Part of this is having a sense of humor. I guess about a year and a half ago when I first started getting back lecturing, I was giving a lecture in Massachusetts to an audience. And there were a lot of people there who I knew, and they were okay. And there were some people who didn't know me, and they were a little like, I could see they were a little like, we don't know how to react. And then I said to them, right in the beginning, I said, understand one thing. There is nobody in dentistry who understands change like Ann Koch understands change. And so everybody laughed and realized, oh my God, it's okay to laugh. Absolutely, it's okay to laugh with me. That's different laughing with somebody than laughing at somebody. Nobody wants anybody laughing at them. But, it's okay to make some different things. So like when I say, like, nobody knows change like me, that's meant to be funny, and it's fun.
What do you think your biggest legacy will be? You've had so much on the endo, so much on social issues.
It's really kind of interesting because one of the things that's my big interest outside of endodontics is women's issues. And there have been people who've been physicians who've transitioned and they kind of disappeared. Well, wait a second, you are a physician and you transitioned and now you're working in a CVS? That's not quite right. No knock against anybody working in a CVS, but what I've done, which I'm very, very proud of, is that I was at a level in endodontics and I went away and transitioned, fought through whatever I had to fight through, and now I'm back up to where I was before. That's not done, hasn't really been done too much in the medical field. I mean, there's a couple of people who are transsexual surgeons who are transgender women themselves, but one has always been in that world. The other one had been successful as a guy. A bit of a legacy that I've been able to show people that you can come back and reestablish yourself. But for me, I'm really pushing the women's issues because I can't believe now how difficult it is for women to get things accomplished. And it's so funny because when I speak to women, and I have a lot of female girlfriends, and back in Cape Cod where I live, most people just see me as Annie, as kind of a tall blonde woman. If people know or if people ask, I have no problem, no hesitation telling them. There's another part of my life where I'm going around the country speaking on transgender healthcare so everybody knows. But with women, I couldn't believe how much more difficult it is for women to get things accomplished in medicine and dentistry as compared to an old white guy. And I have the unique of being kind of a successful old white guy. And now I'm kind of hopefully successful as kind of a mature white woman. But one of the things is that when I look at this, there are differences, and I'm trying to address those issues because misogyny is worse now, I think, in medicine, meaning dental medicine, veterinary medicine, dental medicine, than 1973. And part of this are different people coming from cultures where misogyny is not only tolerated, it's promoted. That can't go on like that. It can't work like that. And I find myself, Howard, now being a magnet for young women from a lot of Asian countries, Middle Eastern countries, India. They kind of stick to me like Velcro. And I'm very proud to have them. And I'll stand in front of the gun for you ladies. And I like kind of being that kind of banner carrier. I have no problem doing that. And what's so funny is all women, women will tell you this, oh, men don't know how to multitask. Absolutely correct. A guy, give him a can of beer, a remote control, they're watching ESPN, done. But what women don't understand about guys is guys do some things so much better than women. And one of these things is prioritizing. If you give a guy 4 or 5 things to do, as you know, men do a calculus. They do a calculus like, how is this going to affect me? How is this going to affect my images? How is this going to affect me financially? How is this going to affect me going forward? And guys do a calculus where I'm going to concentrate on this and they blow off the other 3 things. And women don't do that. But guys do that, and guys get things done. And my experience has been women, the female CEOs I've met, kind of think like a guy in that. You can't do everything. Sometimes you have to make a decision. You've got to concentrate on this. I'll come back to the other ones maybe at a later date, but you've got to go with this.
Why do you think the United States has never had a woman president and the Fortune 500 is 95% men?
I think there's 2 different things on that. I think with the Fortune 500, I think that's going to be changing. I think one of the things in the past that men could get away at the end of the day, kind of always holding the kid card over women, that women aren't fully committed because they want to have a family. I know women where that's been very difficult when they've had kids and have a life that it takes away from their job at hand. They couldn't fully. But I know a lot of women who don't have children and never plan to have children are just as dedicated. So I think you're going to see some changes. Also in the past, you had women, and if their husband, or a partner, but generally a husband, if they were transferred, they would go with the husband.
Right.
So what happened? All of a sudden, they brought that chain of continuity was broken. So they were working their way up in the company. All of a sudden, it's gone because now they're working on the West Coast, not the East Coast.
I've seen this situation in my backyard. The man is making $60,000 a year.
Right.
The woman has an established practice that's
Right.
at $750.
Guy leaves and they leave.
She's making $200.
Right.
Gets transferred to Seattle.
Right.
She's bawling in my front room.
Right.
She has to decide
Right.
to follow him, which she did.
All the time. Happens
And it's
all
like,
the time.
why don't you just tell that dumb idiot that since you make 3 times more? And she says, well, it's emancipating or it's emasculating to him that I make 3 times as much money. And I said, well, tell him not to think about that when he's vacuuming.
Right. I like that. I like that.
I mean, I told him. I mean, it's tough because you can't tell him to go.
Yeah.
They got kids. It's just so sad.
Well, it's really difficult, and I mean, again, guys can play the intimidation card. Guys play the family card. Guys play a family card against female associates on the medical and dental side all the time. And I have to tell you a funny thing. I used to have a little club in Boston, which I no longer have, and it was mainly female professionals. And we're like only about 9 or 10 people, and there were basically like 7 young dentists, 2 physicians. And they just knew me as Annie, and we would meet in a restaurant. And one night I'm there, and there's always an alpha female or an alpha male in every group. So the alpha female in this group was a young Korean woman who's a dentist in Boston. So we're talking about some stuff, and for about half an hour, and then she said, listen, Annie, she said, I don't think I told you this, but we were all talking in a parking lot before we came up tonight that you've had like such an amazing life. You've done so many things. We all realize that we think that you probably know men really well. Can we speak to you about men? So I said, yes, I think I know guys really pretty well. So we talked about men, and of course, 2 of them were treating guys with like total dead ends, like get rid of this guy's stat, right? Listen, honey, if it's not working for you now, it's not going to get better with time. So it's kind of fun for me. And then I've had other women where, and especially with my tennis friends, where they'll be talking afterwards, and just understand for all the men out there, with a girls' night out, you can't have a guy. One guy ruins the dynamics of any GNO. So if you have a couple of women, it's your wife, your girlfriend, whatever, and they having a girls' night out, don't go and crash it. Doesn't work. So I was with a couple of girlfriends, and they were saying like, gosh, Annie, you have such insight into men. It's amazing. Then they said, oh, it's because of kind of your field. Your field is so male-dominated. That's why you have such a keen insight into men. If that's the story and you want to go with it, I'm going with that story. But it is different. It is Mars and Venus. And I think it's not so easy. I think relationships are really, really difficult. And this is a great lead into my own personal relationship. I think my wife, who's Japanese, and transsexual people in Japan have been there for gazillion of years. They have no problem. Buddhist countries see 3 different sexes. It's very different than in the United States. She knew about it. I had written her a letter before we got married saying that I don't think this would be an issue, but there's a possibility that this could be an issue, that I've kind of always felt like being a woman. So it was no surprise. But what happened, what really, I think, threw her over the edge was the response of my friends. My friends were like, oh my God, the sky is falling. This is the end of the world. That it pushed this little Japanese woman kind of over the edge where I've got to have a divorce. And having a divorce in Florida is an expensive divorce.
Why? Why Florida?
50%.
Yeah.
And fortunately, she was gracious enough to understand I was trying to, like, don't focus on 50%, just focus like this is the number. That's kind of incredible. The good news here is that she's come back. And actually, a couple of summers ago, she was visiting.
She came back from Japan, back
well,
to Florida?
no, she part of the settlement, and she now lives in a gorgeous, drop-dead 37th floor oceanfront condo in Hawaii. And so she's likes the lifestyle, she's doing it, but she's become, still remains a great friend. And, you know, I would be less than honest if I didn't say I wish I could kind of repair that situation so it became like an 8-month, 4-month thing, or maybe a 6 and 6, because there's great companionship. And we still enjoy each other's company when we're together. So we just, who knows where things go. But really what pushed her over the ledge initially, I think, was just the fact that she saw all this exaggerated response, and I think she thought this must be incredibly toxic. When, like, wait a second.
And what % of that came from religious people?
I have found with my own thing, religious people were impossible to judge. I had some people who, like my brother, thought maybe I was going to go to hell. I had some other religious people who were incredibly supportive. I found no correlation between political parties. I had some kind of liberal democratic friends who I thought were going to embrace this. That wasn't the case. I had some people who I know as very right-wing people who thought that they were going to get at it, and they were incredibly supportive. So it's really hard to predict where that support or where the non-support's going to come from.
It's true. A lot of people who are very conservative are conservative and financial, but liberal. And
very like libertarians.
Yeah.
Like you can do what you want to do.
But when you talk about women's issues, it almost makes me want to cry of the woman dentist. I don't want to get into politics and religion and all that, but she was in the Middle East, and when their country had a revolt, when the new group of crazies found out she was a woman dentist who had male patients, they killed her.
Right.
And I posted her picture, and I mean, can you imagine being a woman dentist getting killed for treating a male?
Yeah, and that's why...
Yeah.
Well... That's why, you know, one of the things in the last few years in the States, I think there's been a tremendous amount of improvement in terms of, you know, LGBT issues. And I think, you know, I have a lot of gay friends. My gay friends are great fun for me. And it's always kind of fun because they're always saying that, you know, my gay friends say, well, we don't say you're fabulous unless you really are fabulous. Yeah. So I think that is a great compliment from my gay friends. And I have a number of, obviously, of course, lesbian friends. But I think, you know, the way I've looked at this, the group that was many light years behind was the whole trans group. And there's many more challenges associated with that group. But at least finally, I think that group's being viewed in a little bit different light. The reason I go around to medical conferences, and again, in terms of, I have found most trans people I've met have kind of gone back into kind of a transgender non-conforming world. That's not me. I live in what people would refer to as a perfectly maybe straight world. I don't consider it straight. Massachusetts is a regular world. Massachusetts has no bearing if you're gay, straight, lesbian, trans. So I just lead my life. I lead my life hitting tennis balls. I like having a drink, sitting on a boat in the fall, hair back, sweater, corduroys, having a gin and tonic. That works for me. Giving an endodontic lecture works for me.
I'm going to go back to women's issues and the fact that so many women, that'd be the majority, and then a few gay, tell me that they don't like going to their study club because it's a good old white boy club. And I've had African American dentists, gay dentists, a lot of women dentists. And then I know, so maybe, what's your advice on? Do you think you should be talking to the men saying, hey, this is what they're feeling? You can argue facts, but you can't argue feelings.
No.
So if you think you're a good person, but minority black, minority women, minority gay, transgender are afraid or don't like to come, what would you say to all the people in study clubs where they're all a bunch of white males?
Well, one of the things here is that they really one of the things that has happened, and maybe this is a bit of the legacy, I lecture Howard very similarly to how I lectured as a guy. I never was tethered to a podium. I walked around the room. When Dennis and I would go overseas, Dennis would be at the front of the podium. I'd work the audience like Jerry Springer. Who knew? That should have been a harbinger. But it worked, and it gets the audience engaged. I lecture as a woman, and there's very few women who lecture the way I do. I really make it personal. I'm out in the audience. Unfortunately, I have found women to be more conservative in terms of how they're lecturing. And then, of course, it's a tough deal for women because if you come across a little bit too aggressive, they're not going to be viewed as being feminine and stuff like that. So it's really tough for women to find that sweet spot for them. For me, and especially in the past, having done a lot of the commercials and modeling, I realized it's not gender specific. If you can get out and you can kind of rock it and kind of do things, that's personality based, not so much gender. I'd like to see more of these clubs bring in women as lecturers. I'm going to be doing a lecture with Lynn Brock, who's an endodontist down in Alabama, but it's for the Mississippi Dental Association. So, here are these two blonde women, two endodontists. We're going to be doing this lecture, and she's not a wallflower, and I'm not a wallflower, and we're going to rock it. And I want to see more of that happen. But in terms of good old white boys clubs, that kind of stuff, yeah, that exists, and I think that's going to be a while before that totally changes around. But there's a couple of things here that's different. It's an age-related thing, and you see it in schools now, especially in medical schools. The awareness of women's issues, the awareness of gay and lesbian issues. Don't hang old Dr. Cohen because he said a joke. Listen, just speak to him like things have changed. It's the younger guys in the 40s. That's the group that has to understand that this kind of bullshit no longer goes. It's a different time. So, people have to work through this. They have to speak to their members like, wait a second, times have changed. And I know in education times have changed. It's really tough getting millennials to come out to a conference. Guys your age, my age, people in their 40s, but you get this 28, 32, it's tough.
Well, some of it's just because they're so fun. Well, some of it's just insane, like Chicago Midwinter.
Right.
February, really? Is that your favorite time to visit Chicago?
No, but that's normally a meeting that has a big attendance. But now what happens also, there's a group, you have to realize this group is so comfortable with technology. It's the proverbial Thanksgiving dinner, and the cousins are texting each other across the table.
But you've lectured around the world.
Right.
When you lecture in Germany, they have beer and wine and food. Right. Have you ever been to a lecture in the United States where there were beer and wine?
No. What I've done with Dennis and I used to do this. We used to do dinner lectures at Real World Endo, where we would actually have a free buffet dinner and enjoy the dinner while we're talking.
Yeah.
So I'm walking around when you're having a croissant. I'm speaking about bioceramics.
It's funny how these big meetings, attendance is drifting down, but it's not down enough to where they're willing to start making any changes.
I think I saw a welcome change this year at the Long Island Dental meeting, and I had a lecture slot that was kind of a graveyard slot, meaning 6 to 9. But what was really interesting was that I got a chance to spend time at that meeting. And the evening before, it was packed because they had so much food and drinks. They had white wine, red wine, Prosecco, beer, all kinds of different ethnic foods. Oh my God, it kept everybody in house.
It's the funniest thing when you say New York. I grew up in Kansas. And we're always told New York City is the biggest city in America.
Right.
And there is no New York City.
Right.
When you go to New York City, you say, "Oh, do you live in New York City?" "No, I live in Manhattan." "No, I'm in Brooklyn." "No, I'm in Queens."
Right.
I'm in Staten Island. There is no New York City. You'll never meet a dentist in your life that says, "Yeah, I live in New York City." They say, it's kind of funny that way, isn't it?
Exactly. But that's what makes New York so much fun. You have all these different things. But I think it is a challenge for dental education. I think, the dependency upon technology, the typodonts, the sim labs, the animation, the sim lab doesn't grab your handpiece. So that's a challenge for us, right? But it's really the truth. So what I'm seeing, and I know case-based learning very well, and case-based learning works if the students are really motivated.
I want to ask you a personal question, then an endo question. To me, it's so confusing growing up in Kansas. The Koch brothers are the most. There's like 4 billionaire brothers,
and one of them,
and it's Koch,
and one of them lives fairly close to me on Cape Cod.
He was the one kicked out, right?
I don't know which one it was because I know one brother went, I think, to MIT, and the other brother maybe went to MIT as well. But
that reminds me, you went to Harvard.
Well, I went to Penn, but then I started the Endodontic program at Harvard. Yes.
Can I tell you my favorite Harvard MIT joke?
No, please.
So someone's at the grocery store, and the sign says 10 items or less, and he has 12 items. So the clerk says, "You're either from Harvard and can't count, or you're from MIT and can't read."
Be careful what you say when you say that in Cambridge.
Because MIT is known for their math, and Harvard's known for all their social. So they're going to see your Koch,
right?
And some are going to say Koch, and some are going to say Koch.
Right.
Why are there two different sounds to the same name?
Well, the real German pronunciation is Koch, which means cook in German, and Koch is kind of like a little bit, even in Pennsylvania Dutch, in the Amish country and stuff in Pennsylvania, they kind of pronounce it kind of as a Koch, a little bit more like Koch. But the Anglo kind of pronunciation of it was Koch. And it was kind of interesting because it's by the heritage of that. It's a German name meaning cook. But there's a lot of other people with Polish names, Russian names, where they've shortened it to Koch, like Koczynski to Koch, that kind of stuff. So Koch now is not just German. There's a lot of variation. Ed Koch, think of Ed Koch in New York City.
Your last name means cook.
Right.
So are you a good cook?
Let me tell you about this. One of the things at this point in my life, after going through everything I'm going through, I don't fake and I don't do a false modesty thing. There are some things I know how to do. There are some things I know how to do well. There are some things I'm totally clueless about. And so if you want me to cook a really restaurant quality, like rib roast, I'm clueless. Now, fish, seafood, I know how to do that stuff. And it was so funny because last year, Sing-Ko Kim, that person I had mentioned earlier, he came up to visit for a week, and I showed him how to open oysters. And you have to realize this is a world-famous microsurgeon. He's a DMD, PhD, MD type guy. So anywhere he goes, or even anywhere I go with microsurgery courses, they just assume that, well, you've been trained. Dr. Kim, Dr. Koch, you've been trained. They're not impressed. But the fact that we can open oysters, they're so completely, totally impressed, okay?
That was one of the best decisions I made. I had 3 of my 4 boys living here, or all 4 bachelors. Right. And we hired a cook. What was her name? Anne, or...
That was when I was going to college in Flagler.
Oh, and we brought in a cook, and she came in, and I think we had 10 lessons, and everybody went to a different level of cooking. But I want to ask you another question. I'll let you go. Thanks for staying overtime. My guest's supposed to stay an hour. You're already at an hour 20. Here's a big dilemma that I want you to put on your mom hat. They come out of dental school. They're $350,000 in debt.
They're lucky if they're $350, not $500.
Yeah, and you have to be good in sales to sell bleaching, bonding, veneers, these big cases, these rehabs, and they're shy and they're introvert. But endo, they're in pain. They're begging you. They're like, "Hey, can you help me?" And almost half the graduates that walk out of dental school just say, "I hate endo."
Right.
I've had so many people. One of them said to me, "I'd rather be taken out in the backyard and beat with a stick than do endo."
Okay.
So, but it's $1,000 and insurance pays 80%, and the patient's begging you to do it.
So
what do you say to that 24-year-old?
I guess I put the sunnies on as the unknown endodontist. I put the sunnies on as fun because a lot of times with my residents we'll have pictures kind of like with the sunnies, kind of like, it makes me think of that old lady who's on the cards, the lady with the glaucoma glasses. You have touched into something that is right in my wheelhouse. One of my biggest things, and I have no problem speaking how I feel, ever since you've known me, I've always been that way. In the past, my big complaint was about undergraduate endodontic education. And people would say, Annie, at the time it was Ken, don't get so upset, it's no different than orthodontics. Wait a second, there's a huge difference, because in orthodontics, there's no such thing as an emergency. There's an inconvenience. You lose an elastic, maybe you broke an arch wire. It's not a catastrophe, it's an inconvenience. But in endo, you can have somebody a week out of dental school, they're working for their first job, somebody comes in with a cellulitis and their eyes closed. That's a whole different procedure. So the idea that you're not taught a lot of endodontics in undergraduate education is not the same as ortho. I'm here to tell you every endodontic graduate program in North America is excellent. They've got great young men and women as residents. They do a terrific job teaching and promoting endodontics, especially teaching. So the graduate programs are great. Where there is enormous variation in endodontic education is on the undergraduate level. I was at UNLV yesterday, on Friday. They have some students who've done more than 50 molars as an undergraduate dental student. 50 molars as an undergraduate dental student? I've been also many places where recent graduates have come out, they did 1 or 2 teeth. Sometimes they never did a tooth, just typodonts. There's enormous variation. One of the things I used to have with my residents at Harvard, and I said to them very quickly, before you as a graduate student, as an endodontic resident, can take a case from an undergraduate student and do a surgery or a complicated case, you have to find a replacement case for the student. So when I put that edict in place, it got a lot of barking and chirping. And I said, there's no discussion here. So they said, what do you mean, Dr. Koch? Dr. Koch is pretty reasonable. How come there was no discussion? It was so obvious to me. Here was my answer. They also pay tuition. So I think it's terrible that undergraduate dental students are not getting the exposure in perio and in endo, and let's stay restricted to endo, that they deserve to get. And the thing to me is what has happened now, and this is kind of interesting, I just had a conversation this morning with Ali Naseh. I see an opportunity for Real World Endo and for Ali and myself teaching basic generic endodontics.
I wish you'd do it online at Dentaltown.
We're going to do it online at Dentaltown.
So, Annie, tell me this. 30 years ago today,
Right.
I graduated 30 years ago, May 11, 87. When I was in dental school 30 years ago, we had 6 full-time endodontists, and the class size was 120.
Right.
There's a dental school up the street from here.
Right.
Has 1 board-certified endodontist.
Right.
How can one guy teach the whole damn school endo?
Well, that's a problem. And so this is a problem when you get into dental education in terms of how can they recruit faculty. Full-time faculty is very difficult to recruit. Obviously in endodontics, it's just like I have never been at any DSO ever. I've never lectured at any DSO where they did not try to hire me. Has nothing to do with me personally. It just has to do with that I'm an endodontist, okay? But part-time, schools have to make an effort to bring in some part-time people. In running a graduate program, a school is only as good as your part-time faculty. And now if you have a dental school that only has an undergraduate endodontic component, no postdoc program, you've got to bring in some part-time endodontists to help out on the undergraduate level. I totally believe in that. And again, one of the things for me is that the pendulum is now swinging back. Will Genoble was a perio resident at Harvard when I was running my endodontic program. And let me tell you what I did. When my endodontic residents were doing an endodontic surgery, you know who was assisting them? Joe Ferrellini's perio residents. And when Joe's periodontal residents were doing perio surgery, you know who was assisting them? My endo guys. That way you get an appreciation, right, for what the other person's doing. Anyway, Will Genoble was a perio resident with Dr. Ferrellini. Will now is the chairman of periodontology at the University of Michigan. He's also the editor of the Journal of Dental Research. That's a serious journal. And last May, he had an article talking about, failure rates with implants vis-a-vis endo and periomucositis, periimplantitis, things like that. That started this swing. Now what we're seeing this big swing coming back towards dentition-based prosthesis. In Boston, it's gotten so out of control now that endodontists are telling the perio guys and the pros guys, especially the pros guys, I can't save it. It's fractured. I can't save it. So it's gone from one extreme where somebody had a short fill 1/3 the way down a canal of being extracted and having a fixture placed to now where prosthodontists are trying to have endodontists save teeth that are fractured that need to be extracted. So as we go more into this dentition-based trend, it's really incumbent upon young dental graduates, young general dentists, young restorative dentists to understand what endodontics can do, what endodontics cannot do. And I think it's an opportunity for them. So I see this as a great opportunity for Ollie and I to teach generic endodontics to reach a lot of young dentists.
Another stressful question a lot of endodontists have is whether or not they should learn to place implants. What is your view on an endodontist?
Well, it's interesting because when endodontists first started treating implants, I said to them, excuse me, have you ever had a patient come back and say to you, or you have a patient in a chair, well, I'm not going anywhere, the temporary is not right? They said, well, no, they never did any restorative or any kind of prosthodontic dentistry. So, I've had. If you're going to be doing implants, you have to understand, placing an implant to me is pretty easy. It's a lot easier than doing a mandibular molar apicolectomy. The big things, and you can offer your opinion, but the big thing to me about implants is soft tissue management and treatment planning. Soft tissue management, you can't have little dark triangles between 6 and 7 and 7 and 8 and 8 and 9 and 9. You can't have that. So your embrasure space, the management of the papilla, that's something that a lot of endodontists that I've known in the past didn't have any background in. So yeah, placing a fixture is pretty easy, and I understand that. So I think it's up to the individual. But if you're going to be placing fixtures as an endodontist, I want you to understand keenly soft tissue management and treatment planning.
I want to...
That makes sense to you from your perspective?
Absolutely. And thanks for staying on overtime.
Are you kidding me?
I've been going overtime.
Don't ask Ann Koch a question. Off I go.
I'm greedy on your time. When I got out of school, I see young millennials who are $500,000 in debt. Every time they want to take a course, they got to get in a jet airplane, fly across the country, stay in a resort, drop $3,000 a weekend. I think it's crazy.
Right.
What I used to do is just walk across the street or drive, and I would ask these specialists if I could assist them. And I saw there were two types. Half of them were hope, growth, and abundance. Right. And say, come on in. Half were fear and scarcity. Like, well, if you wanted to have it done right, give it to me.
Right.
And what do you think about these young kids who are sitting in a town of and they see these specialists, but they're scared. They don't want to knock on your door because this is what they say to me. They don't want me to learn because they want the money themselves. Why would they teach me? What would you say? What would your advice be?
That's a feeling among certain specialists. There's no doubt about that. I've always had it just the opposite way. And I'm probably not in the majority, but I don't think I'm in the super large minority. I think it's getting closer and closer to like maybe a 60-40 type of thing. But here's my feeling. If you're a specialist, and let's talk about endodontics, if you're an endodontist, you're an education source for that entire area. You're an education source for all your referral dentists. And my attitude is, understand that they're going to do some of these easier cases just because the financial aspect. If you reach out and you create a relationship where you're educating your general dental referral base, because it's a referral business, how to do some other cases easily, how to do these basic cases easily and well, I think by creating the relationship, you can let them know why they need to send the more difficult cases to you. And when it does, it's a referral business. There's room for everybody. What I have seen, because I've spent so much time in medicine in the last few years, let me just do a quick sidebar. The only thing that physicians do better than we do as dentists, there's one thing that they do better, and they do a lot better than dentists. You know what that is? They don't criticize each other. You could leave behind a hemostat or a sponge, and the other physician's not going to say anything negative. In dentistry, you go to a dental office, I think I can get my root canal closer to the end of the root. I think I can make that crown better. That looks like a C3 to me. I think you're more of an A2.5. Okay? So we should be a little bit more considerate of criticizing each other in dentistry. Physicians are very good at that. Other than that,
physicians never brag about some equipment they bought. You'll never see an ad saying, "Oh, we bought the new deluxe MRI or ultras." And dentists are like, "I have a same-day dentistry. I have a laser."
Right, and so in dentistry, we have a continuity of care. We have a follow-up. But one of the things that physicians I've seen in the surgical specialties, I've seen young surgeons reach out to older, more experienced people if they could kind of like watch them. The senior surgeons, the only concern they have is, I don't want you saying that you did training with me specifically. So some of them will limit it to like a week. Some of them may limit it to 2 weeks. But what they are doing, they're kind of reaching out and even just observing. And I think that is something in dentistry that you just almost never hear of anymore.
What specialties are more open to sharing their knowledge with their referrals versus no way, close my door?
To me, I thought for years the best specialty out there in terms of sharing their knowledge and information was endodontics.
Agreed.
Okay, I mean, endodontists were the guys out there. And one of the things I did when I was running my program at Harvard, I had my endodontic residents teach the rest of the school, meaning undergraduate dental students and other postdoc residents, how to get patients profoundly numb. Not numb, profoundly numb. And there's a trick, and it shouldn't just be the bailiwick of endodontists and oral surgeons. So I have always felt and held to the belief that endodontists were the best about sharing their specialty. I can also tell you, when I spoke at the AAE this year, and when I spoke at the ADEA meeting, I think this was the keynote where they had this on tape, I have never been more proud in my life to be a dentist than I was at that lecture. That's come a long way when all of a sudden I'm a keynote speaker being a very visible transsexual woman. I see myself as a woman. If you want to make it officially like, okay, as a guy, so I'm officially a transsexual woman. Everything works, everything looks totally natal. But still, that's a bit of a stretch to have me as a keynote at a dental meeting. I think they deserve a lot of credit for that. And for the AAE this year to have me as, a speaker twice, I think that says a lot. And what it says is stuff that's positive.
Last question.
Absolutely.
There's a lot of old guys, meaning I'm 54, that every molar root canal they do, they give a Penn VK 500 milligram and 16 tabs of Vicodin.
Yeah.
And so, talk to that. I mean, do you agree or disagree?
No, I disagree with that. I'm
saying, do you agree that there's a lot of dentists out there that do that?
Yes, absolutely. And actually some specialists. And I'm 67, so I've been around. I was practicing dentistry before we had gloves. We had gloves. We only used them for furniture, okay? I also was around. I just mentioned it the other day. Years ago, when we used to do pin-retained amalgams, when I was in the service, I used to call them Brunswick amalgams. And they say, Brunswick? Yes, and 10 pins, right? We'd put pins all kinds of different directions. And we used to actually mix amalgam. And we would add a little bit extra mercury because on those big amalgam buildups, it made it easier to condense. So I've seen a lot of changes come across the table here in 40 plus years. I'm not a person like dental school. Dental schools treat antibiotics sometimes like it's a plague. On the other hand, there are people who use it as a total crutch. There's an indication for antibiotics. Just like there's an indication for implants, there's an indication for root canal therapy. The big thing with antibiotics, in addition to some of these, prophylactic indications, is when there's systemic involvement. So when somebody comes in and they have a tooth that they feel like the head's going to blow off, that's all inflammatory cells. Antibiotic has no effect, and there's no need to give antibiotics on that. If the patient is not swollen and they don't have any type of systemic symptoms, there's no need to give an antibiotic. Now, if somebody comes in swollen, okay, I'm going to give them antibiotics. I've had people argue with me saying, well, wait a second, that's immunologically driven. Well, wait a second, you've never worked as an endodontist. You're an immunologist. You're a PhD guy. I've had some times where people, and this is a clinical sense, and you know what I'm talking about, sometimes if people have a big area and that tooth is symptomatic, I'll give them kind of prophylactic antibiotics after instrumenting it, after the case. So people say, well, that's really not necessarily. Yeah, but then the patient blows up and they come back to my office and the first question they ask you is, how come you didn't give me an antibiotic? So that's the gray area. That's my clinical experience in these cases. But really, the big thing is there are too many dentists giving antibiotics in areas that it's not systemic, it's inflammatory driven. If you have a vital tooth, there's no reason for antibiotics and endodontics.
What antibiotic do you give?
Well, for me, there's a couple of things. For me, the antibiotic I like when I'm using things kind of prophylactically is Penn BK, and that's Penn BK, 500 milligrams, 1 tab QAD, 7 to 10 days. Generally, 7 days is enough, and I'll stop that. If you're going to use antibiotics, use them properly. I'm not a big fan of amoxicillin in endodontic infections because I think it's a little bit too broad. If somebody comes in, and I will tell you right now, between 1991 and 1998, there was probably no endodontist on this planet, I can't speak for Mars and Venus, but there was probably no endodontist on this planet who treated more HIV patients than me. Treated it down in Philadelphia with Michael Glick, and then when I went up to Harvard, I treated all the Fenway and especially the Deaconess. The Deaconess is a very famous hospital in Boston in the Longwood Avenue area that is immunocompromised patients. So these guys would come in on a Friday afternoon, swollen up in a canine fossa. At those years, this is just at the beginning of a cyclovir, they would dump all this medicine on your bracket table. I couldn't IND a hard cellulitis up in the canine fossa. I would put them on clindamycin. And I would put them on clindamycin. They would come back Monday morning, and I would do a non-surgical root canal. So I love clindamycin. I like clindamycin better than metronidazole, which is Flagyl, combined with, like Augmentin, or combine it with, amoxicillin. I like clindamycin because it's really great against anaerobes.
Last question of this.
Okay.
Opioids. It's
right. Out of
all
control.
over the news.
All over the news.
So a lot of people, they're in pain. A lot of doctors, every single molar gets
Right.
18 tab. Some are afraid to. What's your thoughts on opioids?
I've used Vicodin ES in my career very, very little. NSAIDs combined with acetaminophen works really well. Okay,
But why do you say NSAIDs and acetaminophen? It's almost like, is aspirin still a bad guy?
No, but I mean, what has happened is that Elliot Hirsch has some of this stuff where in Pennsylvania, you can Google Elliot Hirsch, HERSH, has some interesting study on pain medication where they've used, ibuprofen combined with acetaminophen. For me, as an endodontist, even in terms of apicoectomies, things like that, apical surgery, we basically, pushed NSAIDs. Would we occasionally write a script for Vicodin or T3? Yeah, we would do that, but that would not be the principal thing.
So how do you prescribe the NSAIDs and ibuprofen?
Well, one of the things that they're doing is they're doing a regular, NSAIDs, which is what 400, milligrams, 600 milligrams. You could do 600 milligrams, 325 of acetaminophen.
At the same time?
Yeah.
Every 4 hours, 6 hours?
Yeah, and you can go back and check that. I would double check on that because to me...
And some people wonder that should you give them that dose before you even start?
I used to start NSAIDs before, and I'm going to say an asterisk here. Right now, when I was actively practicing, I wasn't doing the NSAIDs and acetaminophen. This is something that people are starting to use now, so I would double check exactly on the dose.
Yeah.
Right, but it's NSAIDs and acetaminophen, and I think it's basically 400 to 600 milligrams of ibuprofen combined with 325 acetaminophen. But check that.
Do you think dentists have created a lot of addicts over the years?
I think physicians have created a lot more than dentists. For me, I mean, one of the things that would change in this game for me when I was really actively practicing was Massachusetts is really a great state. Massachusetts cares about 3 things: politics, sports, and revenge. That's Boston, politics, sports, and revenge. But Massachusetts cares about education and healthcare. We would have pharmacists call us, and they would say, Dr. Koch, you just wrote a script for T3. We want to let you know this is the 4th coding prescription this week for this patient. Cancel the script. That's, I think, pretty much all around the nation now, I believe, probably. One way or the other, either you've got to check or you can basically check how much the patient has in terms of these scripts. In Massachusetts, the pharmacist will call you. So the thing
Do they
for me,
have to call you, or this culture?
I believe maybe at the point now it's probably mandatory. I'm not quite certain on that, but Massachusetts is very proactive on that. So the T3s and the Vicodin ES is not being prescribed as much as it was. But for me, the amount that dentists prescribed generally has been very, very minimal. And I think you see physicians keep people on some of that stuff, some of this atypical pain that they have, back pains. So I think physicians have a little bit more culpability in this than the dental market.
I just want to say last thing on a marketing tip. I've been a dentist now 30 years. I've taken all my pharmacists in my zip code to dinner. I've had them out the house.
How great
at
is that?
dinner. You know how many people go up to the pharmacist and say, "Should I buy this Ambisol or what's best for a tooth?" They go see Howard Farran.
Yeah.
And I remember whining and dining Brad. I mean, like within 3 weeks when I got here, and 8% of all emergency room visits are tooth in nature, and I've driven to each one, shook their hands, given them my referral cards, send them cookies with a deal, because the emergency room doesn't want to treat a toothache.
Let me ask you about it. Have you had anybody else in Dentaltown talking about this combination of NSAIDs and acetaminophen?
On a course?
Or even anything, because
so.
because this is getting a lot of publicity out in the schools because the studies, and again, what everybody should Google is Dr. Elliot Hirsch, University of Pennsylvania, and it's basically the studies that they've done, and it's really interesting. Elliot has also developed a nasal dental anesthetic.
Oh yes.
Okay, the same guy, but what he's had a lot of studies on is this combination of
what's his nasal anesthetic called?
I don't know what the name is of it, but I know he's had a nasal anesthetic.
Is he a friend of yours?
No, but he's on the faculty down there.
Okay.
Because
well, introduce us if you remember.
I would love to do that
him.
because please check out, and I'll go back and check out the exact numbers what he has with the ibuprofen plus acetaminophen, because I was kind of surprised, like, in the past it was always kind of one or the other. You kind of gave NSAIDs or you gave acetaminophen. And it was a combination that they had really profound, good results in terms of pain medication. So,
well, I have mixed feelings about opioids, because everybody says how bad Vicodin and Percodan and OxyContin and heroin is, but then when I look at my music collection, it's
well, let me tell you one thing. Let me tell you one thing. You know what day is the worst day of the year for endodontists in terms of people trying to scam drugs?
What?
It's the Wednesday night before Thanksgiving. It's notorious. You get all these calls of people calling up because you're an endodontist, and it's like, "Oh, my tooth hurts. Oh, I'll come. I don't want you to come in. Okay, I can give you a script. All right, I'll call in some, ibuprofen, 600 milligrams. No, that doesn't work for me." Then, of course, they proceed to give you the pharmacology for Vicodin ES. But
So-
Wednesday night before Thanksgiving.
Why Thanksgiving?
Why the what?
Why the night before Thanksgiving?
Because they realize they don't want to bother you. It's a great excuse. Like, I don't want you to come in. It's the night before Thanksgiving. Just call it in. Well,
One last point on Thanksgiving is so funny, because everybody thinks Thanksgiving is turkey and stuffing and apple pie, but Thanksgiving started up in your part of the country, and for the first 100 years it was a seafood fest.
Have some striped bass, codfish, oysters.
Yeah, there was no turkey.
Actually, I would prefer striped bass, codfish, oysters, scallops.
Yeah, that's the original Thanksgiving.
Oh my God! If there's nothing better, there is nothing better in the sea than
I want to tell you.
scallop.
You put up 6 online CE courses on Dentaltown. You were the first one who ever hit 10,000 views on an online CE course. You're a legend. I've seen you lecture so many times when I was getting my FAGD, my MAGD. I just think the world of you, and thank you so much for
Feelings
all
likewise.
that you've done for
And I'm
us.
so thrilled to be back interacting with the Dentaltown community. I'm thrilled.